We're here at the ASCO meeting this year, and we were able to be fortunate enough to present our phase 2 data on natural killer cells from cord blood as a treatment for multiple myeloma. This actually is a culmination of almost 10 years of work, which started out in the laboratory when we realized that natural killer cells actually can kill myeloma and that we could actually get natural killer cells derived from cord blood. So we initially started with trying to expand cord blood cells to make natural killer cells, and we were able to show that they could kill myeloma both in a petri dish and also in a mouse. And thereafter we started a phase 1 trial, which was published last year, of giving natural killer cells in the setting of an autologous transplant. And we were able to show that at least 1 × 10⁸ cells per kilogram, so that's a lot of cells, was safely tolerated. Patients were fine. And because of that, we moved to a phase 2 study where we were really looking to see if we could have efficacy. In this study, 33 patients participated. And if you look at what the patients looked like, at least a third of them had ISS stage 3 disease, a third of them had high-risk cytogenetics or FISH, and a third of them had a history of relapse or progression. All total, about 75% of patients had some adverse feature, which means that these patients were higher risk than your normal patient that would be going through a transplant for myeloma. We were able to see, again, that the cells were fairly safe, well tolerated. We did not have any cytokine release syndrome. We did not have any neurotoxicity, no graft versus host disease. Again, as you may recall, the cells were given in the context of high-dose chemotherapy. So in this situation, the melphalan 200 was given like we would have normally done on a transplant, but 2 days later, the NK cells were infused, and then 5 days later, the stem cell graft was infused. So it's like getting a transplant plus bonus NK cells. We also gave a little bit of lenalidomide during this time because we knew that the lenalidomide might help the NK cells to function better. After we performed the study and analyzed the data, we were able to see again that it was safe. And when we looked at the efficacy at 100 days, so about 3 months out, 79% of patients had a VGPR or better. So that means at least 90% reduction of their disease. Now we know that the chemotherapy was a big part of it, but if you see, that's actually pretty good stats for patients in this sort of a risk category. And when we followed them out so far, 3 patients have died, so we still have more than half alive. Our median follow-up time for patients who are alive is 24 months or so, and we're able to estimate a 3-year progression-free survival of 52%. Now again, this is something that's a little bit less than standard risk myeloma patients would have, but very good for patients who are higher risk myeloma, which 3/4 of these patients appear to be. What do we think about this therapy? Well, we know that the NK cells could be found in the patients, so we know that they're in the patients, we know that we can find them, and we're doing some correlative analyses right now to understand if they're really active and how long they'll stay. We know they stay for at least 5 days, 7 days, maybe longer, but in the future we'd like to see if we could engineer these NK cells or culture them so that they would expand or persist in the patient even after a week or 2, because we want them to fight that myeloma as much as possible. Other things that have been developing in this area are maybe combining NK cells with antibodies, because we know they're good at fighting with antibodies, or maybe engineering the NK cells like the T cells have been engineered to make chimeric antigen receptor NK cells, and now you'd have a killer cell that's really directed towards the myeloma protein. So those are things that we're interested in the future, and we're really grateful to have been able to present this data here at this conference.